Hello, everybody. Thanks for tuning in today for this next chapter of the Chest Board Review series. I'm going to talk to you today about decompensated right heart failure and pulmonary embolism. I have no financial disclosures to reveal. And just to go over the learning objectives for this three-chapter series, we are going to define the clinical syndrome of acute decompensated right heart failure, including the signs and symptoms of the pathophysiology, describe the various etiologies, decompensated right heart failure, treatment goals, and potential complications of treatment. And then we're going to shift over to looking at pulmonary embolism, acute PE, and assessing the risk for poor outcome in PE, describe the indications and contraindications for thrombolytic therapy of pulmonary embolism. So chapter 1, we're going to go through decompensated right heart failure, etiology, treatment goals, and complications. So this chapter will deal with the first two learning objectives. And I think it's important when we discuss right heart failure, we have to understand the normal right ventricular physiology and anatomy, because that will inform how we proceed with this topic. So it's important to keep in mind that under normal conditions, the right ventricular system is a low pressure system. That means that minimal rises in pulmonary arterial pressures will only rise minimally, even when the cardiac output increases. And this is because of recruitable pulmonary vessels. So again, really bringing home the fact that the RV and the pulmonary circulation is a low pressure system. It also has low vascular tone, meaning that there's a relatively low pulmonary vascular resistance or a low afterload that the RV sees under normal conditions. And the PVR is even lower than the SVR, even in situations where you have hypoxemia or hypercarbia. It's a much lower vascular tone vascular bed. Furthermore, the anatomy of the RV is much different than that of the LV, in the sense that the RV anatomy has a large free wall that's wrapped around the medial aspect of the LV or the septum. It's also very thin, on the order of 2 to 3 millimeters in wall thickness at normal. And because it's thin, it is also a lower energy expenditure ventricle than the LV, which all makes sense. We all know this, but it's important to state at the beginning. And because of that, the stroke volume decreases or can decrease abruptly when there are increases in the PVR. So if the vascular tone increases and the afterload to the RV increases, stroke volume will be affected much more dramatically than the stroke volume of the left ventricle when the left ventricle is faced with a high SVR. So speaking to the lack of a muscular ventricle of the RV and the inability to augment stroke volume in the face of increased afterload acutely. And then the other thing to keep in mind is that there is some interventricular dependence between the RV and the LV, such that if the diastolic pressures in the RV reach a certain point, you can actually have bowing of the septum into the left ventricle, or that so-called D-shaped ventricle that will affect preload of the LV and subsequently systemic blood pressure. When we talk about decompensated right heart failure, what are we talking about? What are the symptoms, signs, and lab images that we're going to be looking for in a patient like this when they're coming to our ICU? Well, symptoms are pretty straightforward and relatively nonspecific, like many conditions for which patients would come to the ICU. There's dyspnea, swelling in the lower extremities, ascites would be part of that as well, chest pain occasionally, and syncope if the heart failure is bad enough. Signs that you're going to see on physical exam, you're going to see an elevated jugular venous distension, edema as well, along with ascites. You might even see an RV heave, depending on how chronic the RV failure has been. You'll see tricuspid regurg, either as a primary reason for RV failure or as a result of the change in conformation of the right ventricle causing a functional tricuspid regurg. You can see tachycardia and you can see hypotension, obviously, in extreme cases. Both tachycardia and hypotension in the setting of right heart failure portend a very poor prognosis. And then with the labs and images, most ICU doctors will have already gotten a BNP and a troponin, which are markers of damage to the RV as well. So it's important to sort of keep an eye on that. And that will help us when we talk later about acute PE, will help us risk stratify the patient. TTE will reveal any interventricular dependence, the dilation of the RV itself, and then looking at tricuspid annular excursion is another thing that you can look at to actually judge the health and the contractility of the RV itself. Contrast CTs usually you're getting it in this setting because you're worried about an acute PE, can help you with RV-LV ratio, which again will help you risk stratify in the case of a acute PE or a high risk or intermediate risk PE. And then finally, pulmonary artery catheterization can help not just in the diagnosis or assessment of the degree of right heart failure, but also it can help you titrate medications, which we'll talk about a little bit later in the management of the patient. I want to put up this slide about sort of things that we'll encounter in the ICU with someone with decompensated right heart failure. Now, this talk is not going to go through all the classifications of pH or precapillary, postcapillary. This is more of a talk dealing with what will you do as the intensivist when the patient comes to the ICU, or at least what are the things that you have to take into account when you're managing a patient like this. So what's important to know is when you're dealing with RV failure, usually in the ICU, we're seeing RV failure in the setting of someone with very well-established pulmonary vascular disease. So for example, patient will have connective tissue disease or some sort of pre-existing precapillary or postcapillary pulmonary hypertension. And now they're coming in with an additional insult that is causing them to be decompensated. And it's up to us as the clinician to sort of figure out how best to balance these three things that are on sort of the left side of the slide. Usually in RV failure, you're dealing with excessive preload, excessive afterload in almost every case, or insufficient contractility of the RV itself. Now, the exception to this sort of idea of established pulmonary vascular disease as the predisposing comorbid factor causing RV failure is the case of acute pulmonary embolism. Again, we will discuss acute PE in chapters 2 and 3 of this talk. The goal, which is easier said than done in this condition, is to optimize the RV function while addressing the underlying cause of RV failure. So when we talk about the etiologies, breaking it down by the three classes that we discussed before, the three domains, excessive preload, excessive afterload, or insufficient contractility, various conditions will fall into these sort of categories. So tricuspid regurg and pulmonic regurg, for all intents and purposes, is an example of excessive preload on the RV because of the regurgitant flow through the valves. Excessive afterload, again, much more common and pervasive. And whenever you deal with a patient like this, you're always going to have some element of excessive afterload. That's seen more in cases like acute pulmonary embolism, LV failure, or rather LV failure causing the right heart failure, pulmonic stenosis, pericardial disease. Positive pressure ventilation can increase afterload on the RV. And in most patients, this is not a problem. But if you have someone with established pH and they're already operating at the upper limit of their compensation for their baseline pH, adding an additional insult of excessive afterload, even in the setting of everything else being normal, can cause a problem. ARDS, because of the hypoxemia, acidemia, and hypercarbia that ensues. And then finally, just well-established pH. By definition, most of those patients, almost all those patients have excessive afterload. So this will be in the excessive afterload category. And then finally, in the insufficient contractility, you've got RV infarct, RV cardiomyopathy, a congenital heart disease that's affecting contractility of the RV. Sometimes perioperatively, the RV can be injured in such a way that it does not function and contract the way we would like. And then finally, severe sepsis. We know that there is cardiomyopathy of sepsis that can occur here. Sepsis can also be sort of put into the excessive afterload category, depending on the infectious etiology for the sepsis. But just keep that in mind. This is sort of a constructive way to think about how you would deal with decompensated right heart failure acutely in the ICU. How do we approach the management? Well, again, it's very similar to the previous slide where we're looking at preload, afterload, and contractility. Preload by far is the one that is probably the most difficult to exactly know where the volume status of the patient is in this setting, because again, patients are usually coming in with established pulmonary vascular disease. Their right-sided pressures are already elevated, and they're coming in with an additional insult. So in those patients, if they're hypovolemic, if they're bleeding, for example, then IV fluid might be the right answer, but usually it's not. Usually you're going to base your preload assessment on their afterload, which again can be a very tricky thing because if you give them fluid, you might invoke too much of this interventricular dependence that will affect the LV, the filling of the LV, and subsequently systemic blood pressures. So this is a little bit tricky. You sort of have to be careful about giving too much fluid, and most people would recommend not giving very much fluid, again, unless they're bleeding or they're severely hypovolemic. And then when it comes to RV afterload, this is going to be a factor in almost every case, right? And the mechanisms are usually going to be hypoxemia from the conditions mentioned before, hypercapnia, and thrombosis, perhaps. But the thing you have to be aware of is try to avoid positive pressure ventilation as much as you can. Now, obviously, if the patient is in extremis and needs to be intubated for airway protection or hypoxemia, hypercarbia, then you're going to have to do it. But that carries its own risks, putting someone on positive pressure ventilation who's got severe RV afterload increase. And then finally, insufficient contractility. This is going to be dictated primarily, or will reveal itself primarily by RV distension. What does the RV look like? How distended is it, et cetera? Because there are metabolic derangements that can contribute to contractility that have nothing to do necessarily with RV ischemia, but acidemia or sepsis or things of that sort can affect the contractility independent of any ischemia. Poor oxygen delivery is another thing that would sort of go in the classification of an MI of the RCA. So that's something to be concerned about. And then the wall tension will also dictate the contractility. If the RV wall is stretched very thin, then the myocytes, the cardiomyocytes are not working very well and contractility will be affected. So with that approach in mind and understanding the different variables that are at play, what about some of the specific agents that we can use, like the vasopressors that are available to us? Well, here in the table, you've got a list of vasopressors that should be familiar to all of us, along with the receptor binding sites. And it's a combination of vasopressors and inotropes. The inotropes are at the bottom, the dobutamine and the milrinone. Now, in a perfect world, you'd want to use an agent that increases the systemic vascular resistance and the RV contractility, but not the pulmonary vascular resistance. Now, that's a harder thing to do because a lot of these pressors that we use that affect alpha, so thereby increasing SVR, also cause pulmonary vasoconstriction. So you have to sort of use them in balance and pick an agent that maybe does a little bit of alpha to increase your SVR, but also will hit the beta 1 receptor to cause some increase in contractility. Norepinephrine is generally the one that most of us will try first in these cases, realizing that it may not be enough in and of itself, and that we may have to add an inotrope. And usually in that case, we'll reach for dobutamine because it's fairly easy to use, or milrinone as well. Those are the sort of two inotropes that most folks will use. You want to stay away from phenylephrine because that's pure alpha. So that will not increase contractility, but will definitely worsen PVR. Epi is not a terrible choice either, although that will increase the heart rate a little bit more than the others. So that could be a problem as well. So generally norepi and then an inotrope is usually where we go if the patients are still hypotensive. And then there are pulmonary vasodilators, so affecting the afterload side of the equation, inhaled, intravenous, and oral. I'm not going to get too into the oral agents or even the IV agents, other than to say that they exist. And if patients are coming in on these agents, you have to sort of give consideration of whether you want to continue them. In most cases, you will if they can take them. But generally speaking, if you need to acutely drop the afterload, you're really talking about inhaled nitric oxide, inhaled levoprostenol, or iloprost. But most centers will have inhaled NO or inhaled epoprostenol available to them. And it's a little bit easier to use these because, for one, they're distributed in the areas that are actually receiving ventilation. So they're more likely to cause pulmonary vasodilation in those areas, and you're going to get better VQ matching and ultimately offloading the RV a little bit by decreasing the afterload. Also, because these agents are relatively rapid onset and have a shorter half-life, they just tend to be more applicable to what we're doing in the ICU. And finally, with acute decompensated right heart failure, we're also talking about mechanical circulatory support. And in that case, we're usually talking about VA ECMO. VV ECMO probably wouldn't help because the whole goal here is to try to offload the RV. And most VV ECMO, you're not offloading the RV. You're actually, not really doing anything to the RV other than providing oxygen-rich blood. So in VA ECMO, where you're bypassing the pulmonary circulation altogether, that's a really nice way of offloading the RV. But generally, it's used as a bridge to more definitive procedures such as an endarterectomy or transplantation if the patient is a candidate. And remember the complications of ECMO, which I think most of us are aware of, but bleeding, infection, stroke, and also thromboembolism from the apparatus itself. So this ends the first chapter. Thanks for your attention. Good luck on the boards, and we'll see you in the next chapter.